Okay, hello and welcome everyone. In this video, I'm going to talk about some important observations that Kenneth Arrow had made in this 1963 paper about the healthcare industry. So there's some really important differences between healthcare and some other markets that we might be more familiar with. Importantly, there's this property of unpredictability. It turns out that the demand for healthcare isn't always entirely regular. There's some aspects of the demand for healthcare in terms of like preventative medicine and the annually physicals that people may or may not get that's relatively predictable, but lots of things are following some random distribution of events where people are getting ill or injured. And so this is driving the demand for healthcare. I mean, maybe there's like large epidemics or like a flu season or something like this, but other things equal, the demand for healthcare is not perfectly predictable relative to some other products. There's definitely asymmetric information. Asymmetric information refers to an imbalance of information between consumers and sellers. This is particularly the problem in healthcare because there's often a lack of transparency in terms of, well, prices, quality, these sorts of things. There's also problems of asymmetric information going the other direction, where often consumers might have better information about their own health than, say, would an insurance company. But as a result of consumers not being perfectly well informed about what treatment options are really actually right for them and what the prices are involved, they're going to be placing their trust in medical providers. So trust is the third important characteristic. The idea that, well, patients are going to rely on medical providers, on physicians, to be acting in the patient's interest, not necessarily in the interest of the physician or the healthcare system itself. There's barriers to entry in the sense of there's licensing requirements to enter healthcare, both from the standpoint of like the institutions and the facilities, in terms of like what types of equipment or what types of areas they're able to work in. Similarly, there's licensing requirements on the labor side as well, in terms of who can become a physician, medical provider, physician's assistant, nurse, and so on. So there's barriers to entry, and that's going to confer some degree of market power onto those workers in the labor market, because they're not facing as much competition as they would in the absence of the regulations. Then in terms of payment practices, there's something really unusual in that patients typically are not the ones paying for their own treatment. Maybe you're paying in to insurance in some way, but you're typically not paying incrementally, except for maybe a deductible, in the same way as you would for other large purchases. Here instead, you have payments mediated by an insurance company or some other third party. So this gives rise to a really important observation about healthcare, and then is sort of one of our motivations as we're thinking about the differences between healthcare and maybe what's warranted in this region relative to others. One other observation I'd like to make is that healthcare is a credence good. A credence good is one where the consumer doesn't know the level of the good or service they need prior to purchase, nor do they know the level of the good or service that they've been provided with after the purchase. Right, so there's other credence goods. There's things about there's situations with like auto repair. So if there's something wrong with your car and you take it into the garage to get it fixed, the mechanic can tell you that it was actually a really costly repair, when in reality maybe they needed to do next to nothing to it. They might charge you a large amount, and they may or may not make the big fix. They might do the big fix when it's not warranted, or they might fail to do the big fix that they say that they're making, because after all, only the small fix is required. We have this same aspect in medicine. One of the places where this can become really relevant is the practice of defensive medicine, where you might have medical providers ramping up the level of intervention or level of tests that they're doing out of fear of being held legally responsible should a bad event ultimately happen. Anyway, so there's other issues here, but the basic idea is, well, indeed, healthcare is a credence good. You don't know the level of good or service that you need. You don't know what the best treatment is. And even after you've received the treatment or like a surgery or whatever it is, you don't necessarily know the quality or the level of the good of service you've actually been provided. Very often people don't really know what it is that they're taking, and don't really know what it is that they've been treated with. Instead, this is following directly from the third principle, which is that there's a lot of trust. Consumers are trusting that the medical providers are looking out for them. These are all sorts of things that make the that make the arena of healthcare a little bit different. Here's a paper to sort of reinforce or for further study on credence goods from Uwe Dulick and Rudolf Kirschbeimer. So I saw Dulick present a paper similar to this work when I was in grad school. This paper is on doctors, mechanics, computer specialists, the economics of credence goods, which appeared in the Journal of Economic Literature, which is a relatively accessible journal in terms of like your ability to read through and make sense of it with sort of a basic level of economic understanding, because it's sort of a lot of writing, a lot of verbiage rather than a lot of math. So anyway.